Hi, my name is Sabrina Narain, and today I'm going to be presenting a virtual case presentation on cardiac sarcoidosis for advanced physiology and pathophysiology for nurse practitioners. So first, we'll be talking about the chief complaint and signs and symptoms for this case study. So a 60-year-old African-American female presents to the ER due to a chief complaint of passing out at home while outside doing yard work, for which her husband called EMS. She states she remembers experiencing dizziness and palpitations before passing out, but denies hitting her head. Her husband states she was unconscious only for a minute or two. She also reports occasional chest tightness, which she's been attributing to gastric reflux, swelling in both legs, and progressive dyspnea on exertion in the past few weeks. During the H&P, the patient reported a history of hypertension, coronary artery disease, and COPD, non-oxygen dependent, related to a 20-year smoking history. She does not currently smoke or drink alcohol. While obtaining her family history, the patient reports her mother passed away recently due to heart failure. So chief complaint right now is syncope. So for the first differential diagnosis, I would be most concerned with orthostatic hypotension. Since the patient was outside in the sun doing yard work, it most likely was dehydration that was causing the dizziness and syncope. Second, she reported palpitations along with the dizziness and syncope, which are all signs of possible cardiac arrhythmia. And since the patient has a history of cardiac disease and family history of heart failure, structural heart disease, such as heart valve dysfunction, may also be a possible culprit. For this reason, myocardial infarction is a probability as well, but it's less likely since she did not report common symptoms such as acute chest pain or shortness of breath at the time of syncope, though of course MI can present differently in women. Lastly, she's at high risk for stroke, though it's also less likely since she did not present with any of the normal signs of stroke, and syncope is usually a less common symptom of it. For etiology, cardiac sarcoidosis, which I'll reference to as CS, is a type of cardiomyopathy characterized by inflammatory, non-caseating granulomatous tissue that infiltrates the heart. It is difficult to pinpoint the exact cause of this disorder, but it's believed that it may be due to a combination of factors, including genetics, environment, and immune dysfunction. Correlation has been seen between monozygotic twins and sarcoidosis, as well as certain genes that are associated with the disease, specifically class 2 MHC HLA DR3. And just so you guys know, cardiomyopathy is a disease that weakens the heart muscle and is characterized by thickening, enlargement, and/or stiffening of the heart. And non-caseating granulomas are macrophages and T lymphocytes and do not contain necrotic tissue. For epidemiology, it's been found that CS affects mainly Black individuals more than white individuals, and primarily affects individuals between 25 to 60 years of age, more commonly women than men. For pathophysiology, the exact cause of CS isn't fully understood, but it's believed to be related to an overactive immune system, as well as environmental factors. An increased risk for CS has been seen among firefighters and agricultural workers who are exposed to insecticides, as well as those exposed to certain pathogens, specifically Mycobacteria, Comatophila pneumoniae, and Propion bacterium. It's known that general sarcoidosis involves activation of macrophages and CD4 T cells, which increases the production of tumor necrosis factor alpha, interferon gamma, and expression of amyloid A protein. In CS, this leads to the formation of granulomas, more commonly in the septum and left ventricle. Septal involvement can lead to dysrhythmias, such as AV heart block, bundle branch blocks, VTAC, VFib, SVT, and AFib. Left ventricle involvement can cause dilated cardiomyopathy and mitral valve dysfunction. So, symptoms of CS can vary a lot, as some may be completely asymptomatic and go undiagnosed, while others experience more severe symptoms, such as those of heart failure. Studies show that symptoms can actually differ between different ethnicities, especially Puerto Ricans, Black, and Japanese individuals with CS. Symptoms also depend on where the granulomas form in the heart and the extent of inflammation that they cause. Evidence shows that over time, as scars begin to form on the heart will get weaker, thus leading to more notable symptoms. If an individual does experience symptoms, they're most commonly chest pain, shortness of breath, lower extremity edema, palpitations, syncope, fatigue, and coughing. Physical exam findings that the healthcare provider may see are irregular pulse, pedal edema, jugular vein distension, heart murmurs, and extra heart sounds, as well as pulmonary symptoms when it comes to systemic sarcoidosis. You may just see symptoms kind of everywhere. On the skin, you may see scattered purple skin lesions, red and painful raised bumps on legs, vision changes, and possibly neurological issues such as seizures. So for diagnostics, cardiac MRI and PET scan are the most effective at diagnosing CS. Cardiac MRI, also known as CMR, can show areas of inflammation and fibrosis in the heart through use of a contrast agent. A cardiac PET, also known as FDG-PET, can identify active inflammatory lesions in the heart. More specifically, this test looks at increased FDG uptake, which is a glucose analog that is sequestered in activated inflammatory cells, such as macrophages and lymphocytes, through insulin-dependent glucose transport proteins, specifically GLUT1 and GLUT3, which accumulates in areas of upregulated glucose metabolism, such as hypermetabolic sites of myocardial sarcoidosis infiltration. You can also do an EKG, which may show abnormalities such as conduction delay, AV block, fragmented QRS complexes, left-right bundle branch blocks, PVCs, and various ventricular arrhythmias. A frequent one is VTAC. Another non-invasive method of capturing arrhythmias is Holter monitoring, which can be done outpatient. An echocardiogram may show decreased left ventricular ejection fraction, regional wall aneurysm, basal septal thinning, and abnormal global longitudinal strain. Histological confirmation of CS can be made via endomyocardial biopsy, or EMB, or LV apical core biopsy. However, these are both invasive and they have limited sensitivity due to the patchiness nature of myocardial infiltration. The only biomarkers or labs that may be used are pro-BNP and troponin, which may be elevated, especially when suspecting heart failure, but they don't directly indicate that an individual has CS. So CS it's difficult to diagnose due to its diverse manifestations, because it can mimic other disorders such as acute myocarditis, giant cell myocarditis, and cardiac amyloidosis, just to name a few. It's also important to consider individuals' family history, especially if they have a history of sarcoidosis and/or cardiac disorders. One study that compared several diagnostic criteria among different research articles created two tools that can aid in the diagnosis of CS. This first tool here, this table, can help determine the likelihood of an individual having CS, either having a low probability, high probability, or definite or confirmed CS. And I won't go through all of it, but just to go through the first one, to diagnose definite CS, there would be detection of that non-caseating granuloma with the EMB, that biopsy, and there's no alternative causes identified. Next, the second tool is basically a decision tree that helps healthcare providers decide on what diagnostic tests to use. For example, if we start at the top of this diagram, if a patient is presenting with frequent palpitations and syncope, may have also had abnormal EKG and/or echo, you can proceed with a cardiac MRI, and so on and so forth, depending on the results of each test. So pharmacological treatment, it should only be implemented if there's a high probability of CS and the patient is showing symptoms. Treatment can vary depending on the symptoms that arise, but the first line treatment of CS is corticosteroids, and steroids non-selectively suppress production of cytokines involved in granuloma formation, including TNF-alpha and INF-gamma. inhibiting inflammatory cell migration and restoring CD4 T cell function, as well as the balance between the subtypes of effector CD4 T cells. In other words, corticosteroids help decrease inflammation and can reduce many symptoms, especially related to pulmonary disease. Prednisone is usually the drug of choice, and it can be given PO or IV at 0.5 to 1 milligrams per kilogram daily, then tapered. Second line are immunosuppressant drugs such as methotrexate, which is started low around 5 to 15 milligrams weekly and then titrated upwards to max 20 milligrams weekly. Methotrexate inhibits the metabolism of folic acid in purine and pyrimidine synthesis. This is used to treat symptoms of systemic sarcoidosis when steroids are ineffective or can be used in combination with steroids. Lastly, third-line treatment is TNF biologic agents such as TNF alpha inhibitors. Two examples are infliximab and adalimumab. As the name implies, TNF alpha inhibitors block TNF, which inhibits the formation of granulomas. These meds are typically used in refractory pulmonary sarcoidosis, but often have unwanted adverse effects such as worsening heart failure and are therefore less often utilized. When managing symptoms of sarcoidosis related to cardiomyopathy, guideline-directed medical therapy can vary depending on ejection fraction and specificity and severity of symptoms. Medications can include beta blockers, combined ARBs with neprilysin inhibitors, mineralocorticoid receptor antagonists, and sodium glucose cotransporter 2 inhibitors, which can all help manage left ventricular dysfunction. Diuretics can also be used for fluid volume overload related to CHF. And then advanced treatment of heart failure can include ablation for those experiencing frequent arrhythmias such as VTAC, ICD or LVAD implantation for those with ejection fraction less than 35% and are experiencing arrhythmias, and then heart transplantation for those with decompensated heart failure in which all other standard treatments fail. So for non-pharmacological approaches, they can help with minor symptoms such as dyspnea, cough, fatigue, depression, anxiety. This includes pulmonary rehabilitation, physical therapy, psychosocial, psychological counseling. Individuals can also make lifestyle changes, such as increasing physical activity, smoking cessation, decreasing the use or avoiding alcohol completely, stress management, and then also changes to diet, such as following a heart healthy or low sodium or anti-inflammatory diet, since this disease process is inflammatory. So cultural and socioeconomics studies show that the highest incidence of sarcoidosis and subsequent mortality rates are in Black individuals, which is suspected to be to a genetic component, but may also be related to factors such as limited healthcare access, socioeconomic status, and severity of the disease at the time of presentation. It is believed that there is a higher rate of mortality in women with sarcoidosis as well, of which currently the reasons are unclear and more research is needed. So from my understanding, after reading several different articles, because of the difficulty of diagnosis of systemic sarcoidosis in general, because of the varying symptoms regardless of ethnicity or gender, people are either not getting diagnosed or they're getting diagnosed later when the sarcoidosis eventually affects the heart and starts causing symptoms that get so bad that they finally see a healthcare provider. There isn't much information that I saw that can help to solve this issue. All I can say is that healthcare providers should be educating themselves on this disease process and being more aware of the symptoms, and be more vigilant during physical exams and interviews with patients to screen for sarcoidosis. So, prognosis and expected health outcomes. Postmortem studies have revealed that 25 to 30% of deceased individuals with sarcoidosis had myocardial involvement yet went undiagnosed. This is most likely due to varying symptoms that are mistaken for infections, autoimmune, cardiovascular, and drug-induced disorders. Due to late diagnosis of CS because of its varying symptoms, mimicking up many other disorders, mortality rates may be increased. However, because of increased research, diagnosis, and treatment of CS in recent years, One notable study showed that the prognosis of individuals with this disorder is now a 5-year survival rate of about 96% and a 10-year survival rate of about 86%, which is a lot better compared to earlier studies that demonstrate a 5-year survival rate of only 60%. Individuals diagnosed with cardiac sarcoidosis tend to have worse prognoses compared to those with other types of sarcoidosis due to the increased scarring of heart tissue and muscle that eventually leads to the heart failure. So for teaching and anticipatory guidance, when you're talking to patients, you just want to simplify the explanation of the disease process, talking about like its chronic and relapsing nature so they kind of know what to expect. We went through several different medications. You can go through those and talk about the side effects also so they can expect that. You want to educate on non-pharmacological approaches as well. Like we said, encouraging physical activity is tolerated, the heart-healthy, anti-inflammatory diet, stop smoking, and all that. But you can also include infection prevention, which is good to know while you're on immunosuppressants. You can also educate on certain procedures and devices that they may be going for, such as ablation, ICD, LVAD implant, and post-heart transplant, as well as the Holter monitoring. You also want to make sure to tell them to follow up with recommended healthcare providers for specific testing and treatment. In this case, most likely cardiology for cardiac MRI and PET scan, and then most likely pulmonology as well. And then lastly, you just want to make sure they're aware of like what symptoms to look out for when it's getting worse, when CHF symptoms are getting worse, and that they know when to reach out to the healthcare provider and or go to the ER. And these are my references.